Hello and welcome, ladies and gentlemen. Good morning, good afternoon, or good evening, wherever you are in the world. We are delighted to have you join us for this second live webinar in the series entitled Key Components in the Management of Central Precocious Puberty. And today's webinar is entitled Early Identification of Central Precocious Puberty Patients Requiring GnRH Analog Therapy. My name is Martin Savage. I'm speaking to you from London. And these are my disclosures. And it's a very great pleasure to introduce to you our speaker today, who is Professor Anders Juul from Copenhagen in Denmark. Anders is one of a small group of truly global authorities in reproductive endocrinology in children and adolescents. He has led his unit in Copenhagen to publish an enormous amount on all aspects or many aspects of reproductive endocrinology, but particularly on the investigation and management of early puberty. So it's really a great privilege to have Anders with us today. I will introduce him again in a moment. This webinar series has a group of supporters comprising from the United Kingdom, APES in Malaysia, Australia, and Italy, and also from SLEP, the Latin American Society of Pediatric Endocrinology, and from the UK. We're grateful for these organizations for supporting this series. So these are the partnerships which have been established by Medea, the organization running the webinar. And this independent educational program is made possible thanks to educational sponsorship provided by Ipsen Pharma. So we're delighted to welcome many participants from a very wide range of countries. It's remarkable that we are able to offer this type of educational spread around the world, and I think this is an enormous advance in terms of educational initiatives. So welcome everybody. The learning objectives of this morning's webinar are to distinguish between gonadotrophin-dependent central precocious puberty and early normal puberty, and also to differentiate between variables indicating gonadotrophin dependence. So the agenda is shown here. After my short introduction, I will introduce the presentation by Anders Juul. I'm going to ask you to fill out some questions briefly, actually, before we start the presentation, and the presentation will be followed by a panel discussion, and we will address as many of the questions that you put to us as we can. And I'm looking forward to a lively discussion period after the lecture. There will then be a post-webinar survey, and we will conclude in 1 hour with some concluding remarks. This webinar has been accredited by the European Accreditation Council for Continuing Medical Education, And we would ask you please to fill out the post-webinar survey, which is of crucial importance to us to gauge the quality of this type of education. And having done that, we will send you individually certificates of attendance by email. There is simultaneous translation, so please choose the language, either English or Spanish, that you would like to hear the presentation in. And please submit your questions on the Q&A section that will come through to us and will be ready for us to address after the lecture. So this is a short survey, which we will get some questions now. Okay, I think they will come up. So I'm going to just give you a few seconds to answer each of these. There are 5 questions. Precocious puberty is defined by the appearance of secondary sexual characteristics before 6 years of age in girls, 7 years of age in girls, 8 years of age in girls, or 9 years of age in girls. Please fill that out. And the next one. The biochemical gold standard to define central precocious puberty in girls is serum estradiol, serum inhibin B, basal FSH, or GnRH stimulated LH concentration. Questions will be repeated at the end just to gauge the value of our educational exercise. Next one, please. Will be coming up. The best predictor of pubertal GnRH result, in other words, an LH value of greater than 5 international units, is bone age advancement, basal LH, urinary LH, or a combination of factors. Question number 4. Will appear, here it is. This is in terms of rating your confidence in distinguishing between gonadotrophin-dependent central precocious puberty and early normal puberty, excellent, very good, adequate, needs improvement, or poor. And thanks for your honesty in completing this question. And finally, a question relating to your competence. Please rate your competence in differentiating between variables indicating gonadotrophin dependence. Excellent, very good, adequate, needs improvement, or poor. So thank you for completing these questions. And we now move on, and as I'm delighted to introduce you to give a presentation entitled Early Identification of Central Precocious Puberty Patients requiring GnRH analog therapy. Over to you. Thank you.
Thank you very much. And good day, good morning, good evening to all of you. And thank you for the kind introduction, Martin. I'm pleased to share with you some results and thoughts and experiences when it comes to identifying girls with early puberty who would actually benefit from potential GnRH analog therapy. And these are my disclosures. And these are, again, the learning objectives that you saw just before. Hopefully, by the end of my talk, you will have my view on how to distinguish between gonadotropin-dependent precocious puberty and early normal puberty, and also which variables we can use to make this distinction for whom to treat with GnRH analog and whom not to treat. So I will start with a case that probably is very familiar to a girl like that is probably familiar to most of you. This is a around 4-year-old girl referred to us for precocious puberty, and you can see that she has clearly breast development, very tender and sore breast development, but no pubic hair. You can see on her growth chart that she has growth acceleration in the last year. And upon an X-ray of the left hand, you can see that she has a advanced bone age corresponding to older biological age. And these are the baseline reproductive assessments. Here, your hormones detectable estradiol of 48 picomoles per liter by mass spectrometry, clearly elevated for a prepubertal girl. And in this case, she was, of course, in puberty, negative tumor markers, and a GnRH test, which gave a pubertal response with a stimulated LH level of 6.9 international units. And therefore, as she has a central elicited puberty, we did a brain MRI, which in this case was completely normal. So we decided she had central precocious puberty and put her on a 6-monthly GnRH agonist therapy, which we have monitored with growth and clinical staging every 3 to 6 months, and occasionally a bone age and measurements of reproductive hormones to ensure appropriate suppression by the GnRH analog. So a very typical, straightforward case. This was meant to be, at least. But in a lot of cases, it's not as straightforward, and the girls are 6, 7, or 8 years, or even 9 years, and then you start to think, is this a central elicited precocious puberty, or is it just a normal early variant, or is it just premature thelarche without gonadotropin stimulation? So first of all, I will share with you how frequent is this precocious puberty, at least in Denmark. And in Denmark, we are in the unique situation that we have these nationwide registries, and every time a child is born, it is given a unique ID number. So we can follow them throughout their life in Denmark. Whenever they have a pocket ticket, we can track their income, and we can also track when they have an ICD-10 code registered with a certain diagnosis, or when they die. So that allows us to cover the entire Danish population for how frequent is precocious puberty registered in this 20-year period. And the picture here simply depicts my colleague, Elvira, who is a reproductive epidemiologist, and then she did the statistics here. And if you look here on this 20-year period, you will see, if you just look at the upper, which incorporates all diagnoses of early pubertal variants, you can see that for all diagnoses and that there's a marked increase in this 20-year period more than 7,000 girls were diagnosed in this 20-year period. In Denmark, we are 5.6 million people for comparison, so this gives you the incidence rates shown on the y-axis. We don't know why this increase is occurring. It could be increased awareness among doctors and parents, but it could also be, and probably is, lifestyle related, obesity, exposure to chemicals with hormone mimicking actions, etc. And it's not a Danish phenomenon. It was originally shown, this early puberty boom in the US. And here we have data from South Korea showing the same tendency of, as I just reported from Denmark, of a marked increase in the last 10-year period from 2004 to 10 in precocious puberty among girls. So when we have a girl referred for precocious puberty, and I say girl because it's 1 out of 5 to 1 in girl-boy ratio, when a girl is referred for early puberty, it is classically defined as appearance of secondary sexual characteristics below age 8. And you can argue whether that holds true nowadays when the timing of puberty in the entire population is shifting towards earlier ages. But that's a matter of another debate right now. So when we have this girl referred, we do a clinical investigation of the pubertal signs, evaluate growth pattern, bone age, measure baseline reproductive hormones using ultrasensitive assays, which is key in this context. And then if in doubt, we do a GnRH test, which is still considered the gold standard to diagnose centrally elicited precocious puberty, CPP. And if we find evidence of gonadotropin dependence, elevated gonadotropins, either basal levels or stimulated levels, it's also a common practice to do a brain MRI to rule out any anomalies in the central nervous system. But how frequent do we find something on such a brain MRI? Well, we looked at this 10 years back in a series of 229 girls who had a brain MRI done because of early puberty. And in this series, we found 16 of these girls who had a brain anomaly, which included not only, it was not 16 malignant brain tumors, that's very important to state, but actually it was just brain anomalies associated with precocious puberty. I just show you a few examples here of a pontine epidermoid tumor, a typical arachnoid cyst, or the most common finding is a hypothalamic hamartoma, as shown here. In this girl, age 6.5, when she developed secondary sexual characteristics. And here we found a girl who had a pilocytic astrocytoma who developed into a malignant tumor, and she was hypophysiectomized. So in this case, and what you notice here also that some of the girls were actually quite old, 8.2 years old, at the first appearance of breast development. And that's why we have been slightly reluctant to reduce the age at which you should do a brain MRI, because we did find in this series some who were 7 or 8 years old. But this is debated worldwide. And therefore, we did another study just recently published where we looked at another 205 consecutive children in the last 10-year period. And here we found 6 children altogether, 3 girls and 3 boys, and who had something going on. And here in the middle, upper middle, you see again a hypothalamic hamartoma in this population. So, and here we didn't find any brain anomalies in children above age 6. So we were a little curious on what was actually present in the literature on findings on brain MRI, and search the literature. And this busy table, don't look at it, but it simply illustrates all the existing publications with brain MRI in girls with precocious puberty, including our 2 studies that I just showed you. And at the bottom here, you see that the combination of all studies, which includes more than 4,000 girls with precocious puberty who had a brain MRI done, out of those 4,000, 223 had a brain anomaly corresponding to 5.5%. So I think that is a nice take-home message, is that when you do a brain MRI in a girl with a central precocious puberty, in 5 to 6%, you will be likely to find some anomaly, but not necessarily something that needs operation. It can just be a cyst or a hypothalamic hamartoma that needs surveillance. So when we do in this initial evaluation of a girl, figure out whether we should do a brain MRI and subsequently if we should offer therapy, we do a GNRH test, and which is, as I said before, is the gold standard. And there are several ways to do this. In our country, we use synthetic GNRH, and so it's not a long-acting analog, but it's a short-acting GNRH. We inject it IV, and after 30 minutes, you have a rise in LH and FSH, and this is a prepubertal response. And if LH is rising to above 5, we will call this a central response or pubertal response to a GNRH test. And also you will see that in those with central precocious puberty, you have LH dominance above FSH upon stimulation, whereas in premature thelake or prepubertal children, you will have an FSH predominant response to a GNRH test. I mentioned the 5 international units as the cutoff, which is generally accepted worldwide. But I think I would like to draw your attention to this study we did, or some of my colleagues did, in girls aged 1 to 6 years of age. So if you look at the left side of this graph, you will see the rise in LH during a GNRH test. And these 1 to 6 year old girls, they were all prepubertal, no signs of puberty, and all reproductive hormones were suggestive of a prepubertal girl. And here you see the rise in LH in these prepubertal girls. And if you separate on the right side the maximal LH during this test according to age, you will see that in those below 3 years of age, it's quite common to increase up to almost 10 international units per liter. Above 3 years of age, it's the cutoff of 5 corresponding to 2 standard deviation holds true. So it's very true to use 5 as a cutoff in children, but only in those above 3 years of age. Below 3 years of age, please remember that it's normal for a prepubertal girl to increase to much higher LH levels due to the endogenous mini-puberty. I think it's very important take-home message here. So we should avoid treating girls 2 years of age with GNRH for 10 years based on a LH level above 6. That would be wrong. Now, going back to what do we find when girls are being referred to us, and when we try to assess from reproductive hormones whether or not they have a central precocious puberty or premature thelake, whether they should have brain MRI or not, whether they should be offered GNRH analog therapy or not. And in this series here, we looked at more than 800 girls referred to our single tertiary unit in this period here, and you can see how we excluded early normal variants and those with premature thelake, those with peripheral and central congenital adrenal hyperplasia, etc., leaving us with 181 girls with central precocious puberty. So we compared the 95 with premature thelake, here shown in blue on the left, to those with central precocious puberty on the right. And what we are comparing is a basal LH level measured with an ultrasensitive assay. You should note that this is a logarithmic scale on the y-axis, and you can see that some have elevated LH even for premature thelage, and some have not. And the same pattern is shown for those with true central precocious puberty. Yet they all have a pubertal GnRH test. So we could not really separate clearly premature thelage from precocious puberty of CNS from a basal LH. We could not either separate those children with central precocious puberty who have a brain anomaly that's shown on the right now. This is organic central precocious puberty, and their LH levels were simply overlapping those found in girls with a normal brain MRI, so idiopathic central precocious puberty. So it was a little discouraging that even with the use of ultrasensitive LH assays, we could not really distinguish the groups from each other. We did, however, find that a basal LH level here shown towards the peak LH level in a GnRH test, that there's a linear correlation, and the insert figure here shows that a basal LH showed the best diagnostic performance in terms of predicting a pubertal GnRH test. So it's better than FSH, estradiol, and inhibin B. And these ROC curves here, the bigger the area under the curve, the better diagnostic performance. So an ideal test would simply go up to the upper left corner, and a test without any diagnostic performance would be identical to the line of identity. So you can see here that the blue line ROC curve for LH is the best one. Now, so a serum LH was not superior, and then we tried to look at other ways of measuring gonadotrophin secretion, and you know that there's a marked diurnal secretion with peaks during nighttime, especially in the early onset puberty, which is not reflected by the LH level observed during the opening hours of the outpatient clinic. So that's why we tried to collect a overnight urine sample and measure LH and FSH to see if it, which probably reflects the nocturnal gonadotrophin secretion better. And this is a very new paper published by our Finnish colleagues based on our data. And what it shows here is the overnight LH secretion in boys and girls respectively, and the age at which they increase. So this is age and urinary LH, and the age at which they increase above an arbitrary cutoff, in this case 0.7. And I think the interesting finding here was that actually the age at which urinary LH started to increase was the same in boys and girls. This was a little surprising to me, because we know that girls mature earlier than boys, but in terms of biochemical onset of puberty, we found that they started at the same time, but obviously it took many more years in boys to obtain clinical signs of puberty by testicular growth, and very shortly after LH rise in urine, girls develop breast development. So this was a longitudinal study. We also looked at this some years back using the same assay and measured urinary LH and FSH. And here you see the serum FSH in girls and boys on the top, and then the urinary FSH in the middle, and in the bottom expressed either as total concentration or expressed per 8 hours. And the blue dots are the prepubertal children, and the red dots are the pubertal children. And as I said, girls on the left, boys on the right. So we have reference ranges for urinary gonadotrophin excretion, and here you see the same reference ranges now for urinary LH levels. The lines here and the gray dots are now the healthy children. And what you notice here is that the red triangles are girls diagnosed with central precocious puberty, and those with the blue triangles are those girls with premature thelarche. So you can see that the sensory precocious puberty girls have much higher urinary LH excretion, but there is some overlapping, so it's not ideal either. And when we do so this is the same graph you just saw before, and then do a ROC curve, you can see that urinary LH is slightly better than a serum LH in predicting a pubertal GnRH test. The blue line has a bigger, greater area under the curve. And when we then put these girls on GnRH analog therapy, here you see the decline on therapy on their stimulated serum LH levels. And if we also look at the basal serum LH levels, you can see that there's a tendency that they go down on GnRH analog, but not in all cases. So it's a little confusing just to evaluate the degree of suppression by a basal LH in this here, as opposed to when you look at urinary LH secretion, they all decreased significantly upon GnRH analog below the upper normal range. Sorry. This experience with urinary gonadotrophins has also been found in other studies here from South Korea, published in 2019, and again also an Israeli study from 2021, where they also found that urinary LH excretion was actually a good marker to screen for rapidly progressive puberty in girls. Finally, I will end with some very novel data published just a few weeks ago. And these two ladies this is Amanda, who is the medical student who was first authoring it, and this is Rikke Bech Jensen, who co-supervised Amanda together with me. And in this study, we looked at the girls referred to our department to see if we could better predict those who would need GnRH analog therapy than we could in the past. And again, here we evaluated a larger series of 1,300 girls being referred, and ended up in the bottom here after excluding all those with congenital adrenal hyperplasia, etc., having those with idiopathic organic sensory precocious puberty and premature thelarche. So we looked at a large number of clinical and biochemical parameters comparing idiopathic sensory precocious puberty and premature thelarche. So up here you see age and height, etc., and weight. And if you focus on the lower panels, the middle and the right here you see the bone age advancement in girls with sensory precocious puberty and in those with premature thelarche. So girls with sensory precocious puberty have a significantly more advanced bone ages compared to premature thelarche. But I think the take home is that the values on the bone ages are largely overlapping. So you cannot from a bone age distinguish one group from the other. And the same goes for the height velocities shown down here in the lower right panel. Height velocities is higher in CPP, but there's a big overlap. So you cannot use any of these clinical parameters in isolation to distinguish sensory precocious puberty from premature thelarche. And then we compared the biochemical parameters shown here. And a lot of different hormones, and you do not need to look at all of them. It's just to get a sort of a pattern recognition that you can see that basal LH is much higher in CPP compared to premature thelarche, but overlapping. Testosterone higher, but overlapping. Inhibin B higher, but overlapping. And actually, when you look at individual hormones comparing these two groups, doing again ROC curves as shown here, remember, the bigger the area under the curve, the better the diagnostic performance. You can see here bone age advancement, estradiol, and then that basal LH outranks any other parameter, even though we know that this is not an ideal parameter to distinguish those two groups and who would benefit from GnRH analog therapy. So in isolation, none of the clinical or biochemical parameters are useful to securely distinguish between the two groups. That's why we try to see, can we come up with another option? Can we combine all these parameters and do a principal component analysis where we combine variables in a joint model? And this is what we did here. So in this principal component analysis, we included bone age advancement, IGF-1, basal LH, basal FSH, and then we looked at this combined parameter and found on the ROC curve that it was superior to any of the ROC curves on the isolated parameters. So I'm not saying here that this is what you should all do in the future, combine these four parameters, but I'm saying that perhaps we should look at our data again and use artificial intelligence to see if we can combine parameters and in this way improve the diagnostic differentiation between CPP and premature Thielake, hereby leaving the GnRH test redundant, hopefully in the future, and be better to identify those girls who need a brain MRI and those girls who may benefit from a GnRH analog therapy, i.e. have a GnRH dependent precocious puberty. And to sum up what I have told you, I think we went through the brain MRI findings. 5.5% have a brain anomaly. It's still debated at which age you should do a brain MRI. I can tell you that in our department, we reduced the age from 8 to 7 years of age because we rarely find anything on a brain MRI above age 7 nowadays in our recent series. You should evaluate a girl using sensitive assays, ultra-sensitive gonadotrophin assays, and except if basal LH is clearly elevated above 0.3 international units per liter, it's still considered the gold standard to do a GnRH test, and peak LH above 5 international units per liter corresponds to a central activation of the HPG axis. But please remember again that those girls below age 3 can have much higher stimulated LH levels and not be in puberty. I think I have convinced you, I hope at least, that there's no single individual biomarker, clinical or biochemical, that securely predicts CPP versus premature Thielake. We may lend some support and hope to new markers such as urinary LH excretion because it reflects the overnight pulsatile LH secretion. But I think the take-home message is probably that if we combine several clinical and biochemical parameters in a joint model, PCA, principal component analysis, using machine learning, we may in the future be better to identify those children who may not only avoid unnecessary GnRH testing, but also avoid unnecessary brain MRI, and importantly, avoid GnRH analog therapy unless it is indicated. So I think with that, I would like to thank you for your attention, and this is my group from Copenhagen, saluting you all over the world. Thank you for your attention.
Wonderful. Thank you so much, Anders, for a beautifully clear and very instructive presentation. Now, I'm waiting for some questions to come through on the Q&A, so please write your questions. Let me start by asking you, I know this is a rather soft variable, but I remember seeing patients, and if you ask the mother if there is an obvious change in the degree of pubertal development, somehow in early normal puberty or premature thelarchy, often you don't get a positive response. But in gonadotrophin dependent precocious puberty, you usually get an obvious, yes, I have seen a change. But I agree, I know it's over time and it's probably not quantifiable. But have you found that helpful at all in distinguishing these patients?
I think that's a brilliant question. It's the $10 million question, because I think but it's very difficult to quantify, as you said. I mean, we have to rely on parental reported breast development, or in some cases from the girl herself. But it is a very it's difficult, and that's why we sometimes see the girls when she's above 8, but they can clearly say, well, when we went on vacation to Spain, there were breast budding, no doubt about it, and she was only 7.5 years at that time. And sometimes then, as happens in all normal girls, you have this coming and going breast in 30% of girls. So it intermittent. Sometimes it disappears upon referral, but sometimes it remains there. And I agree with your clinical impression is that when parents report that it's progressing and becoming more and more evident, there's much more likelihood that this is an ongoing central, rapidly progressing, compared to when they say, oh, we just noticed by chance, and sometimes we couldn't see it, etc. But it's difficult to get evidence to support it directly. But
Right. Okay. Thank you. Okay, so we've got some questions coming through now. How long overnight should urine be collected for urinary LH and FSH?
That's again a good question. What we did from a practical point of view, we asked the children to report, or their parents to report, in the healthy children, last void in the evening before they went to bed. And if they went up and peed during the middle of the night, they reported that time point. And then we collected the first morning void, or they did. So they had a container at home and collected it for the morning, and then we corrected for the collection period depending on time of void and last void. We're now trying to see if we can get similar reports, just having a spot urine collection at the time when they show up in the outpatient clinic, because it would be a little more practical, easy to apply a spot urine analysis compared to a collection at home and bringing it to the hospital, but that remains to be seen.
So I must say, I didn't know that there was a significant diurnal variation of LH secretion. So is a collection at night more likely to produce a positive response, a positive result?
Yes, I would say that, because there are some historical studies, among others from Gothenburg, but also elsewhere in the world, looking at 10-minute samplings of LH in serum during the 24 hours. And just in the very early pubertal stages, you see these nocturnal pulses quite clearly, and then during daytime it's more or less flat. So that's why I would say that the overnight collection is more likely to capture these night fluctuations with the onset of puberty.
Great. Okay, thank you. So another question, I think, from Peru. Can you thank you for a great presentation. In many countries, we do not have a GnRH test available. Which test would you consider to be most reliable in that situation, where there's no GnRH available for testing?
That's a good point, and I have to say I don't have a personal experience losing the GnRH analog, but I know that is being used in many places in the world, that you simply administer GnRH analog and then measure stimulate not after 30 minutes, but then after a longer period of time, and how that compared to the short-acting GnRH, I'm not quite sure, to be honest. So it's a good question. I can't give you the precise answer on when to administer, but that is the only existing alternative to dynamic testing of the HPG axis. That's using the long-acting GnRH analog, which you use for therapy.
But maybe a basal LH could be helpful in that situation.
Absolutely. I would say that a basal LH, and we do not do a GnRH test if a basal LH is above 0.3. I think that's indicative of, you will in most cases, or almost 100% cases, find a positive GnRH test or pubertal reply. So just having elevated basal LH is the second best absolutely parameter to predict a central precocious puberty.
Okay, now just let me go into these ultra-sensitive assays. I mean, how widely are they used in clinical practice? Is it quite unusual to have an ultra-sensitive assay?
I think nowadays it's not that rare. Actually, the by far most sensitive assay from a company actually in Finland is no longer available. But there are, with these new platforms, some of them actually have quite assay platforms have quite sensitive gonadotropin assays with a detection limit down to 0.06 or 7 international units, which is what you need and which is nice. But some platforms, and that's why I always put an alert to this topic and mention it, some platforms, biochemical platforms, they are designed to monitor adult women in fertility treatment. And especially for estradiol also, they have enormously high limit of detection corresponding to 90 picomoles per liter, which makes it completely useless in pediatric endocrinology. So that's why I'm arguing that ultrasensitive gonadotropin assays should be used, and I would say that in 6 out of 10, that's a postulate. I don't know for certain, but when we've done a European survey, and I think actually 60% or so actually replied that they used ultrasensitive assays. So it is available, but 40% did not have access to that. And then you have to be careful using a basal LH level, especially because it may be erroneously elevated if it's not a sensitive assay.
Right. Okay. That's a very good point. Thank you. So, how often do you look at bone age, for example, or looking for bone age advance? How often? Every 6 months? Every 12 months?
I think our practice have changed over the years. Initially, or going back when I started 20, 30 years ago, we would do a bone age at the start of therapy, and then we would repeat it every year, more or less, sometimes even after 6 months in the beginning, if we were in doubt that the therapy was effective. At that time, we used monthly GnRH analog, and we did a lot of repeat GnRH tests and repeat bone ages. I think we are a little more reluctant to do this testing, but simply follow the children once they are on the analog. We follow them with an annual bone age, not every year maybe, but every second year, but at least after the first 12 months, I think it's nice to be reassured that bone advancement has been stopped, and so we are and have some sort of biochemical measure that we have GnRH suppression, adequate suppression. You could argue the other way around, and that's the reason why we don't use it as much as before. The bone age and the biochemical monitoring is perhaps when we are treating children with GnRH analog, we are not making them prepubertal again. Actually, we are castrating them entirely. And perhaps that's not sound in terms of ensuring a continuous growth rate at a prepubertal rate. If you're completely suppressing it down, maybe you're over suppressing children. And I think that is what I've done in the past, probably over suppressed because I want everything completely shut down, and maybe it's not needed, and maybe it's even unwanted to suppress it entirely. So a little more reluctant to do bone ages, but at least after 1 year.
Yeah. Okay. Thank you. And at your 1 year monitoring, would you do a GnRH test to make sure that they're suppressed, or would you just look at basal LH, or what would you look at biochemically?
I think maybe it's a mental thing, but I think it's nice to see in a follow-up GnRH test after having subjected a child to many years of therapy that actually you do get the desired result. So sometimes we do it after 6 months, and then we actually do not do it again, and we just follow them with clinical growth and breast palpation and a basal LH on regular intervals. Yeah.
Okay. Thank you. So another question: does a response to a trial of GnRH is it helpful? The response to a trial of GnRH helpful in the diagnosis of central precocious puberty? If you're not sure,
I think I'm not quite sure what the question in reality implies. I mean, I would not probably, if you're giving a child GnRH analog and puberty progresses, is that what is I don't think I would use a trial. I would rather than refrain from starting therapy. And then if I start therapy, I usually go the full Monty and treat until they're 10, 11 years of age.
Right. Okay. So better to wait if you're not sure. And if it is central precocious puberty, it will reveal itself probably clinically. I think that's good advice. Can you just, I know you said it in your talk, but can you just reinforce that if you do a brain MRI and you see a large hypothalamic hamartoma, basically this should not be operated on? Can you just say that? Because I think it's very important. Some of these hamartomas can be rather alarming, and people may feel, well, you know, we need to give surgery, but that is contraindicated. Can you just reinforce that, please?
Absolutely. It's very important that that not only applies to the hypothalamic hamartoma, but clearly in that case, because they are so visible and large. And I think I remember only one case where actually it was associated with hydrocephalus, etc. They needed some shunting, but that is the very rare case. In most cases, you simply do not do anything.
Yes. Thank you.
It's very important, and that also goes for a lot of the other brain anomalies found that you may find arachnoid cyst, and I remember as part of a Chiari malformation, etc. And sometimes, I mean, we have seen the need for neurosurgical assistance to make with hydrocephalus, etc. But usually you don't drain any cysts or anything; you just observe. So it's
okay. Let me just go through quickly. Just if I can just ask you for a brief response. How many cases of CAH combined with central precocious puberty? I mean, that can occur, obviously.
Absolutely, and we are seeing maybe because we are more likely to measure 17-OHP as part of our initial evaluation, because I think we probably have in the past overlooked some in the beginning, at least some of these late onset CAH where that usually, you know, that when you diagnose them because of virilization, and you put them on hydrocortisone, you suppress their steroid levels, and then they get central precocious puberty. That is the classical withdrawal thing. But actually, some of them present with central precocious puberty. And then if you're not doing a 17-OHP and an ACTH test at the time of you may overlook the actual underlying cause. That they may need GnRH analog therapy anyhow, but it's nice to know whether they have an underlying CAH. So we have a few of those each year.
Yeah, thank you. Very helpful. Okay, well, there's a long sort of case report here, which maybe we can send you by email and ask if you would kindly be willing to answer that question. Let me say, yeah, I mean, you didn't mention ultrasound. In your opinion, does ultrasound of the pelvis have any role in the diagnosis of CPP?
That's a tricky question, because I don't want to put the lights on our ultrasonographers at our hospital, but we used to do it all the time in the past, because we had some very experienced ultrasonographers who would measure the endometrial, the growth of the uterus and the endometrial thickness, and also look at the ovaries. But I think if you have inexperienced ultrasonographers, who they are more likely to see, oh, this is they see some cyst in the ovaries and say this is a clear activation, and this is polycystic ovary syndrome in a young girl of age 8, which I think is wrong. So that's why we limit. I think in the hands of experienced ultrasonographers, it is of course a very nice, you can say, radiological readout of estrogen action on the especially on the uterus and in the endometrium. So in that respect, it is a good marker.
Right. Okay. That's very helpful. Thank you. So we're coming to the end now. Let me see. Could we use GnRH treatment? Actually, I think I'll defer this to the next presentation. There's a question about growth hormone, which we can address in the next webinar. What is the role of bone age in differentiation? Okay, I think we've really covered the majority of the questions. Anders, I'd like to thank you very much indeed. Superb presentation, very, very helpful discussion, and hopefully all the delegates will find it helpful. Thank you very much indeed. It's been a pleasure interacting with you. Thank you.
Thank you, Martin. Thank you.
So let's move on to the final slides. So basically, just to remind you, please complete the post-webinar survey, and we will send you certificates by email. And here we go. And finally, just to remind you that the third live webinar is coming up on the 9th of November. And this will be specifically about the strategy and initiation of GnRH analog therapy for precocious puberty, with an emphasis on long-acting administration. So please put that date, the 9th of November, in your agenda. We look forward to welcoming you again for that webinar. And that completes today's webinar. Thank you very much for joining us. It's been a pleasure to have you with us. We hope you are doing well wherever you are in the world, and we look forward to seeing you again soon. Thank you very much, and goodbye.